Yeah, no, let's go ahead. Let's get started. Good evening, everyone. Thank you for joining us. This is Lashkari, MOASC President, and I'm honored to um, start this presentation and introduce our talk, which is on sequencing treatments in the management of metastatic non-small cell lung cancer. And this webinar is part of our monthly lung cancer series that we've had now for the last couple of years. Our moderator, of course, is Dr. Husain from UC San Diego, and and we have two great panelists joining us today. We have Dr. Andy Zhang from Kaiser. I think Kaiser Riverside, correct? Is that right?
Yes.
All right. And then we also have Dr. Ani Balmanoukian from the Angeles Clinic. And we're excited to have her as she is both of our panelists are lung cancer experts. And of course, you know, this is an area where there's a lot of controversy in terms of what we do for our patients following initial treatment. From that launching pad, I'll give it over to Dr. Husain and we can get going. Thank you.
Perfect. Thank you, Dr. Lashkari. And it truly is a pleasure to be here and be able to have this conversation with Dr. Jang and Dr. Balmanoukian. You know, it's really great to, kind of be together on this panel, partly because to some degree we reflect a large service around counties here in Southern California, which we representation from Los Angeles County, San Diego County, as well as Riverside County. And so thank you all for participating. So, you know, this topic that we'll be discussing today is actually a very important topic, I feel, for both oncologists across wide varieties of practices, whether it be community practice or academic practice, which is after the first line of lung cancer therapy, how are we actually thinking through realistically the appropriate strategies for patients across many lines of therapies? So with this, actually, I'd like to start the conversation by presenting, you know, just some information from some clinical trials actually that have been going on in this space. But where I'd like to really get to is to say practically for oncologists in practice, what is the right strategy to think about after the first line? How do we think through the current standard of care with docetaxel and ramucirumab, or docetaxel alone, or gemcitabine, actually, as that may pertain for certain patients? And how do we think through how and when to think through the right referral patterns and right strategies for clinical trials? So, without further ado, what I will first start off with is some slides from a um, a presentation now from actually a couple of years back that has been a presentation for which hopefully by the end of this year we'll have more information on a study known as the Tropion-Lung01. And that study looks at a medicine known as datopotamab deruxtecan, which is a TROP2 ADC. Some of the early data that we had was actually now a couple years back. And there was recently a press release which showed that there was a statistically beneficial PFS with this antibody drug conjugate compared to docetaxel. I think what's curious about the finding is that it's kind of one of the early signals that a medicine may, at least in this strategy of ADCs, outcompete docetaxel, which has kind of been, unfortunately, a battleground in the second line of lung cancer. We are still waiting on overall survival data from the Tropion-Lung01. And what we just know is from a press release. So we don't have a lot of concrete information in that setting. But what I'll do is I'll kind of just present some of the slides. And this was originally presented by Eddie Guerin from UCLA at the World Lung Cancer Conference. Basically, the trial actually looked at a study design which include relapsed or refractory metastatic lung cancer patients. This first iteration had dose escalation, and there was a number of different doses that were looked at. Importantly, in this Tropion Pan Tumor 01, it included patients with lung cancer, but also included triple negative breast cancer patients and HR positive breast cancer patients. Really, kind of the primary endpoint of this study was to evaluate safety. And so, this was just some demographics as it pertained to the lung cancer patients. Most patients had received prior immune therapy. Most patients had received prior platinum chemotherapy. There was subsets of patients that had received prior tyrosine kinase inhibitor therapy, and seems like majority of those were actually EGFR tyrosine kinase inhibitor therapy. 14 out of the 20% total in the cohort with 4 milligrams per kilogram. And then, we can see, very high percentages in the other cohorts as well, 16 of 18, 19 of 19, these categories. Importantly, this study included both non-squamous patients as well as squamous patients. And as we think through the second line, a natural question is, should we be treating the patients with squamous etiology differently than those patients with squamous, the non-squamous differently than the squamous? Here shows, just some additional details about the prior therapies as well as brain metastasis rate. Importantly, I thought a key component here to talk about was when we talk through how many patients went on to the second line study, about 30, mid 30 percentile range had brain metastases. Really, this is an important characteristic that 1 in 3 patients, as they go on to the second line in lung cancer therapy, will have brain metastases. And how are the trials that are encompassing these patients, or how are we thinking about these patients differently? I think also an area that would love to kind of get some additional thoughts as we go through this discussion today. So here is some of the treatment summaries as it pertains to some of the primary endpoints, which were around safety. And I think some key points here as we looked across datopotamab was that the safety profile was manageable. The most common AE, nausea. Another AE that was seen across different the different doses, stomatitis, alopecia, fatigue, vomiting, decreased appetite, constipation. Infusion reactions were seen with the antibody drug conjugate here across these doses. And also some of the other ones as mentioned over here. I think of particular note when we think about ADCs is how does this affect with ocular adverse events? And, this may be an active area of discussion. Some other ADCs that are currently approved in ovarian cancer, one in particular known as mirvetuximab, requires ocular exams prior to administration with that medicine. I think some other key points just to kind of highlight here, treatment discontinuation rate, 16% across the 4 milligram per kilogram, 14% with the 6 milligram per kilogram, 24% with the 8 milligram per kilogram. Also some dose interruptions, as we can see that increase as we increase the dose, and the dose reduction rate also increases, as we increase the dose. So now let's get to the efficacy. And in speaking about the efficacy here, I think some interesting points is that across the dose, there was an overall response rate in the mid-20s. So I may actually ask panel now, maybe Dr. Balmanoukian, I'll ask you first if you don't mind this point, is just to say, what do you feel is the right benchmark to think about a response rate in the second line in lung cancer? Like what is realistic? What are you seeing in your practice? How do you think and communicate with patients about the expectations in the setting? What are some thoughts here on that matter?
Yeah, I think it's always, as an oncologist, a point of frustration whenever we see our patients progress with frontline therapy and with those with non-small cell lung cancer, only because we know that beyond first line, our second line options are not great. Of course, I'm talking about those who don't necessarily have a targetable mutation. And so talking about docetaxel plus ramucirumab, we're historically talking about response rates of around 10%, 12, 13%. And so I know that the benchmark is pretty low. So for me, when I see response rates of 24, 28%, even though technically those are not high numbers, but I mean, it's almost doubling what we have now in terms of response rates in the second line setting. So it's much better than what we currently have in as our option for second line. So for me, in order to basically get excited about second line treatment option, I do want to see better objective response rates, and I do want to see better progression-free survival and durability of response.
No, that's actually really important. And I think, thank you for adding that point about what we actually are regarding as the most important endpoints here. I also agree that durability of response is very important here to think about. Dr. Jang, actually, I may ask you this point is, a lot of people have commented on a disease control rate as being an adequate endpoint in the space of the second line lung cancer. What do you think about that? Like, is it enough to have stable disease in the second line? How are your patients doing chronically in the setting? Are they having a lot of symptoms? Is it enough just to have stable disease?
I think clearly stable disease is a clinical benefit. And obviously, even though if you did not get a good response, the tumor never grows, patient can continue to benefit. And maybe, if you're stable long enough, there may be a next line of therapy or next new agent that comes on board and, buy patients some more times. As I recall about Dato-DXd, I think 6 or 7 months ago, when I was doing the conference, I did discuss about the Dato-DXd when they did this trial. And I believe that in this trial, I think this was like an all-comer trial, but the non-small cell lung cancer has about 25% in this cohort. And you're right, the response rate is about mid-20, 28%. But I think I remember there's some data when you combine with Dato-DXd plus a checkpoint, you actually elevate that response rate up to like 50 to 60%. But I think the key is not necessarily whether this drug is active or not. This drug is clearly active. The key thing is that always that 11 to 15% of ILDs. And if I recall correctly, 6 milligram per kilogram is the dose that they will take into the next phase. And as I also recall, there's like 10% of grade 5 toxicity there. So I think my point on this is we know the Dato-DXd in lung. I mean, the TROP2 has about 60, maybe 70% expressions in the lung, non-small cell. So you don't need to take the target. The drug is clearly active and maybe single agent and in combination. But I think what we need to be very cautious about is the ILD and also the potential higher than expected grade 5 toxicity.
Yeah. No, I think really important point. And I think gives us some reflection on when we think through which therapies are actually going to be great or good competitors against docetaxel, thinking about, how are we going to sequence these medicines apart from just efficacy, but rather their effects with tolerability? How are we actually going to bring that forward? And you're right, actually, the dose that's been brought forward for datopotamab in the TROPION-Lung01 is actually the 6 milligram per kilogram. I think some key points for that, and I just brought up the press release that had come up, where the press release is one where it shows that, and I don't know if you can see my screen on the press release or no. But basically, and maybe I can kind of just
we cannot. We just see your
Okay.
slide.
Okay.
Yeah.
So maybe now you can see it over here, where it just says over here that datopotamab met its dual endpoint of PFS in the phase 3 study, Tropion Lung 01. Basically, actually, what it says is that, this was a study that compared datopotamab versus docetaxel. And, importantly, met its point for PFS. And then for the dual endpoint of overall survival, the data were not mature enough to see the efficacy in that analysis. They did note, and this is important, Dr. Jang, you had mentioned this as well, is that there were, some grade 5 events. So we'll have to kind of see what that shows. The all-grade interstitial lung disease was consistent with prior clinical trials. There were no new safety signals identified in the study. And just some other kind of points here are that the doses you had mentioned, Dr. Jang, was 6.0 milligrams per kilogram. So it was actually, kind of reflecting that median one actually had the highest response rate on the clinical trial as well. Some key points in the study is, there were patients without actionable oncogenes that were included. And then in the Tropion Lung 01, there were patients who had actionable oncogenes that were previously treated with platinum chemotherapy and targeted therapy. So we'll have to see how the two segments, those patients who had received prior targeted therapy for actionable drivers versus those that didn't, how they, they fared. So I think just some key points there to think about. Just when we think about datopotamab, it's a medicine that against TROP2 IgG1. It has a topoisomerase 1 payload and an exatecan derivative. So that's kind of the composition of that. So again, actually, just wanted to kind of provide that context, because part of this discussion, and as we talk about these different molecules and also the space, is really to kind of think through, where is docetaxel used? How are we thinking about the second line? And where are these new medicines actually really going to usurp a role, kind of in that way?
Dr. Husain, can I bring up a point, and that's regarding the role of, what's a meaningful endpoint for second line or third line therapies, and third line perhaps in those who are, who have targetable mutations in non-small cell lung cancer. This agent, for example, would be used as a third line agent in those patients. So, what are we considering a meaningful endpoint for these trials? I know that in the trial they said that PFS had been met and that there was a trend towards overall survival. I mean, I think the way I would look at this type of this trial and other trials like it to solidify a clear benefit would be overall survival. Since these are patients for whom we're not dealing with numerous treatment options such as breast cancer, where it may be difficult to see overall survival benefit when a trial hasn't matured so much yet. But in a trial like this, I think wouldn't most of us want to see overall survival benefit? And I just wanted to throw out that to the panel.
No, thank you, Dr. Lashkari. I think that's a great point. Maybe I'll provide my opinion first, and then it'd be great to get, Dr. Balmanoukian and Dr. Jang, actually, your point. Actually, from my perspective, lung cancer is a pretty heterogeneous disease. And I think that the first line responsiveness to IO, in some cases, may define that patient's overall survival, whether it be the first line responsiveness to IO or the first line responsiveness to a TKI, and as we saw in the Tropion Lung 01, I mean, they included patients with diverse, biomarkers. So I don't know, I think it's going to require a lens of understanding as we look at the overall survival to say, how are the high PD-L1 patients doing? How is that a reflection of the prior PD-1 that they may have received? How are the PD-L1 negative patients doing? How could that be a reflection of their prior first line? How do the people who had actionable drivers, how are they doing versus those that didn't? Dr. Balmanoukian, what do you think about my comment there? Do you think overall survival is a good benchmark that can be achieved in this way when there's so much heterogeneity here?
Yeah, so heterogeneity is the exact word that I was going to say. I completely agree that, in practice, we see such a spectrum in terms of patient outcomes, depending on their markers, PD-L1 expression. I think in the second line setting, even though we all want to see overall survival, we get very excited, when data comes out showing overall survival. That is always an important benchmark for us. But given the heterogeneity of the disease, especially in the second line setting, because I do agree that it's really all going to be contingent on, the patients do really well in the frontline setting, and then also subsequently what therapy did they receive that had an impact on their overall survival. I think in the second line setting, overall survival data, I don't think we're going to be able to get a really clear picture that's going to reflect on the drug itself, just because of the heterogeneity of the nature of the disease itself. For me, some important benchmarks that I do want to see that I was mentioning before is the duration of response. I think we've all had patients who have, targetable mutation where we treat them with frontline therapy and they have 6-month response. And you say that, well, the data said it should be a lot longer, and we're all disappointed. They go on to second line therapy and they only have a response for 3 to 4 months. And so for me, that's not a meaningful response at all. I'm not going to get excited on a drug that has only 3 to 4 month duration of response. And so response rate, duration of response, and also to your earlier point, disease control rate. Those are all very important benchmarks for me to put a comprehensive picture together as whether the drug would be beneficial to use in the second line setting.
Jang, what do you think about this?
Go ahead.
Oh, no. Actually, Dr. Lashkari, if you have...
I just wanted to ask, this is not a biomarker-driven drug, correct? In other words, we're not measuring the extent of the TROP2 on cancer cells for this drug to be active. I mean, this was for all comers, correct?
Yeah. So the drug has shown efficacy, across TROP expression level, and also one other point is that a lot of lung cancer expresses TROP2, and so when you have, a higher percentage of expression, as well as, kind of it not necessarily correlating as well. I think a big question in this space is this, and should it be called more of a targeted therapy, right, against a target? Or should it be referred to as like a targeted delivery? Should it be regarded as a chemotherapy, in fact? So I think these are some of the things that I think more work is needed to kind of further elucidate. But Dr. Jang, what do you think about that? Actually, how do you, think about this as well?
Well, first of all, I mentioned earlier, this is not going to be you don't have to check the TROP2 expression, because I mentioned about 65% anal, 75% of squamous is going to express this. So I don't think the approval is going to require testing. But I do want to say that, first of all, it's not always easy to show overall survival in the second line setting. And I guess I don't just do lung, I also do variety of cancers. And we know there's many product right now in breast and other tumors type that gets approval without overall survival. But I do want to say that beating Taxol is probably not a tall order. I mean, your single agent response is in the mid-20s. And if you combine with another agent, you're able to push that response close to 50. And we all say that any agent or combination agent, if you're able to, and we talk about that in targeted, therapies. If you have a target agent that you're going to give a 50% or higher response rate, that drug should be the first line agent. So my personal feeling about this is may not be just a single agent Dato-DXd. I think most likely it's going to be in combination of another agent, maybe a checkpoint, maybe another agent, and maybe even chemotherapy. I don't know, but I think it most likely will show, and I'm just postulating. If it didn't show OS, it probably will be a trend favoring OS. That's at least that's what I'm thinking about. By the way, I'm just speaking for other general oncologists that does more than lung, is that general oncology is going to answer one major question here. And they're going to ask, is this drug better than sacituzumab? Right? Because sacituzumab is something we already use day in and day out in breast cancer, and that is a Her3 ADC as well. They have the same target, they only have a different payload. It's a SN38. And if you go ask oncologists who does a lot of breast cancer, they will say, well, I feel very comfortable with sacituzumab. This drug works very well, and we know how to manage the toxicity. Does not give you ILDs. You see, that's a major difference here. It does not give you ILD. So people is going to immediately question about, is this product going to be better than SASI? That's my first question. And second question is, does a pulmonary oncologist ready to deal with ILD where breast cancer people or other people already kind of used to it or start paying a lot more attention to it? And third is, are you ready to start scanning patient every 6 weeks? That's what the breast people are start doing it, because they don't want to see a grade 2 ILD and then you stop therapies. So those are the things that's up and coming in the TROP2 space.
I think those are excellent points, Dr. Jang. And Dr. Jang, I may ask you this actually, just, working at Kaiser and kind of in your setting, firstly, may I ask actually, how easy is it to get a patient in to see pulmonary? Like, is it actually something where patients are getting in pretty promptly under these circumstances? Is it difficult to kind of get patients in to see these different doctors?
It's not difficult at all. Actually, we have a weekly pulmonary conference that we discuss lung cancer cases, or pulmonologist, surgeon that will show up. So even if I don't have maybe patient is going to wait a couple of weeks to see the pulmonologist, I can already present it and discuss with in the multidisciplinary conferences already. So, and sometimes it's just a phone call away. I can just kind of curbside people if I needed to. So there's many different ways of trying to get some answers prior to patient seeing the pulmonologist.
And then I also think actually how, and Dr. Jang, I may ask you this question. I think it's important that the lung cancer field kind of learns from some of the experiences in breast cancer and kind of other cancers in this setting. In your experience, if a medicine is approved across multiple indications, like you had commented about sacituzumab being approved in breast cancer, would you feel more comfortable using a medicine that you're using in different diseases here, if you are more familiar with the toxicity? Or would you be more open to considering looking at different agents that have different toxicities?
Absolutely.
If they have more narrow indication.
Absolutely. And that's exactly what happened, but because sometimes if you got a product that's, revolutionary, the field, or, like in HER2 in breast cancers, you must use it and you have to use it. Then you have to deal with the toxicity that come with it. In this case, it's ILD coming with a DXD. That you have no control over. But if you go into the lung and both products that target TROP2 has the similar response rate in the mid-20s, right? Then the oncologist that does this day in, day out is try to use a product that does not give the patient issues, especially when you're dealing with the lung cancer, right? Because ILD in breast cancer may be a different issue, but most of breast cancer patients do not have lung problem, you see? Now you got a lung cancer patient who has COPD, who has emphysema. Now you got to bring a product that may bring a 10% ILD. Maybe that's why you have grade 5. That's kind of higher than what I expected. So that's a totally different issue. So I would say really for sure, in breast maybe a different story, but in lung, if you can avoid ILD in lung cancer patient, is a major plus, no question about it.
It was great to hear your perspective, on this. Dr. Lashkari, any thoughts you have in your practice, actually kind of thinking about some of these?
I mean, I think these were all excellent points. It's definitely when dealing with toxicities related to these antibody drug conjugates, certainly having a good group of pulmonary folks on your team is really important. You know, and the same issue occurs really for treating our lung cancer patients. I actually think we do have excellent experience using agents, that cause ILD, such as checkpoint therapies following consolidation as a form of consolidation therapy for, stage 3 non-small cell lung cancer patients, where, the ILD rate is higher using durvalumab following radiation. So, I think that, it does create a new, type of side effect that we have to be aware of, but I do think that we have some, familiarity with it. And, obviously we have to be just very cognizant, because the ILD associated with these antibody drug conjugates can be quite severe, and, and obviously we will need to make sure that if they develop it, they're grade 2 or higher, these drugs generally need to be discontinued and not continued further. So I think we can deal with it. Obviously, every new drug comes with new side effects, and I think that's one of the challenges, but also one of the fun things in terms of treating our patients. It's just there has to be a lot of communication. That's what we do in our practice, is that when we initiate patients on these medications, we're having our team communicate with the patients, even within a week of their taking it, having them come back and see us a week later, making sure that they have pulse oximeters at home, check their O2 saturations, and if it drops below a certain level, make sure that they're seen right away.
Really excellent points. Really good points. Just to finish off this discussion here, if we look at the waterfall plot, we can see that patients had response across the different dose levels. In fact, some patients even had a complete response at the 4 milligram or the 6 milligram or the 8 milligram dose. Here shows some of the spider plots that we could see, for patients. And again, some patients are having long-term durability across the different doses. So, the summary over here for this was that in the 6 milligram dose, this was the one that was brought forward again for the phase 3. 28% of patients had an ORR. The duration of response was 10.5 months. And this is also being tested in breast cancer. So I think, Dr. Jang, the question that I asked also is one where, if this medicine was in breast cancer and you could use it in breast or lung, like sacituzumab, would that be an influence in any way or difference? I think just some other points that I'd like to discuss is, we mentioned a lot of heterogeneity in this space. May ask, actually, and this may seem like a intuitive question, but is docetaxel actually the agent that is being used in the second line? Like, how often, and maybe Dr. Balmanoukian, I'll ask you this question, is that how often are you using docetaxel versus gemcitabine versus a different type of agent?
Yeah, I have to tell you, in my practice, I try to avoid docetaxel as much as possible. I can't even remember the last time that I actually had a patient on docetaxel. I've discussed it, but majority of the time, I try to refer patients to a clinical trial as much as I can. And so I try to avoid it, just because the toxicity, the side effects, patients don't feel well, the response rates are low. So I really try to avoid docetaxel as much as possible.
And just speaking to that, though, is, like, let's just say a patient is not a trial candidate, right? Besides docetaxel, are there other strategies that you're using as a standard of care kind of approach in that setting?
Yeah, so I do try to, try to think outside of the box as much as I can for patients. For example, if someone was on chemotherapy and immunotherapy with a single immunotherapy agent and they progressed, depending on their circumstances, if they're not a clinical trial candidate, I may actually try to use, which is not standard of care, but I may try to use dual immunotherapy in the second line setting. If I can combine that with radiation, maybe radiating something. So it really does depend on the patient's case. So I may try to change things around or, think outside of the box as much as possible. It also depends for some patients, for example, if they're on chemotherapy, immunotherapy, and then monotherapy and maintenance immunotherapy, and then they recur in some setting, maybe a year and a half later, really depends. I may just get them back on the original chemotherapy. Really depends on the patient scenario.
I think super interesting point, and I'm actually very curious about your point about the dual IO. So may I ask, actually, have you been in a circumstance of progression on PD-1 and then doing, say, CTLA-4 PD-1 post-progression on the PD-1? And have you seen responses there in that setting, even anecdotally for some of your patients?
I've had disease stability, but not significant success in terms of, say, disease reduction.
It's interesting, actually, we did a clinical trial here at UC San Diego with Ipi-Nivo plus oxaliplatin post-progression on PD-1. And actually, in fact, we did see responses post-progression. And I think, kind of really ascertaining, the differential component across the platinum versus the agent is an area of active interest, really trying to tease that out. But interesting point. And also, I think it is interesting to think about, and I think happening in the community, to some degree, is the use of a dual checkpoint strategy post-progression on PD-1. Dr. Jang, what do you think about that? Actually, have you had patients that you've treated post PD-1 with dual checkpoint, and kind of what has your experience been in that type of circumstance, if you've done that?
Personally, I have not, but couple of things that your trial was a Nivo Ipi plus Oxalim. How do you know how much is from Oxaliplatin, how much is from the Ipi? We don't really know. But I think if you look at the frontline data in metastatic non-small cell lung cancer, no targets, we already start getting the theme that adding a CTLA-4 inhibitor can overcome the single agent PD-1 in PD-1 negative patients. We see that in Poseidon, we see that right in Durvalumab, and we see that in Nivo EP as well. So I think there is some truth to that, that if you want to, if a patient fail a single agent PD-1, you want to do adding a CTLA-4, you may be able to overcome the resistance if the patient has a low PD-L1 expression. At least we got some of those hints from those two major trials. I mean, although there's no definitive trial done, but at least that's some trace that we can learn from. However, one of the things for me is I see everything as well. And recently, I don't know if you're aware of it, in kidney cancers and also in general oncology, this is like a knee-jerk reaction for most oncologists that, hey, if I put a patient on maybe a chemo PD-1 and patient fail the progress after that, it's kind of the knee-jerk reaction that most oncologists will say, well, maybe I'll just keep the PD-1 continue, I keep the checkpoint continue, and I'm switching the backbone, okay? This is very common practice in general oncologists. But recently, if you look at and this is not cancer, I just try to show you an example that may not hold truth. There was a trial that was called the CONTACT-3 that was just published, I think it was in ASCO 2023, in kidney cancers. When they use TKI IOs and you follow by another IO, that IO has completely no activity whatsoever. So I just want to be cautious on that. I don't know whether that will hold true in lung cancers, but there are several emerging data from other cancers that continue IO after IO failure may not be so good. But at least in the frontline setting in metastatic non-small cell lung cancer, we do have data show that adding CTLA-4 may have benefits.
No, I agree with you. There's also a report that came from the FDA that looked at what is the response rate after progression on a PD-1 with continuation of the PD-1. And I know it sounds weird, but they actually calculated, and this was done to establish a benchmark for clinical trials, is that after progression on PD-1, how many patients may ultimately have a response by the continuation of that PD-1? And that response rate is 7%. So that means that just by continuing a PD-1 post-progression, there may be a response rate of 7%. And I think that is also interesting as we compare other response rates when they combine PD-1 post-progression as well.
Well, that might also just be similar to what you might see in placebo as well. So in other words, it's not necessarily the drug, but it could just be the activity of the cancer in that individual.
I think it's an interesting point. And Dr. Jang, I just wanted to make a quick comment about your comment about combining the ADC with datopotamab with PD-1. So that was done in the first line. And currently, we don't have clinical trial data, at least to my knowledge, on Dato plus PD-1 after progression on the PD-1. So we don't know that the response rate will be that high as it was in the first line, where it was in, as you had mentioned, in that 50, mid 50 percentile range. So we just have to see, kind of how that will go. There is a concept of immunogenic cell death and how these agents, may reflect immunogenic cell death or cause immunogenic cell death. We'll just have to see, how that plays out.
So one thing you do know, Taxol alone is not going to give you 50% first line.
Yeah, no, that's a good point. So another question that I have, and Dr. Jang, actually be great to get your point on this, is how often when you do docetaxel, how often are you doing it with ramucirumab? Are you using it a lot with ramucirumab? Are you doing it mainly single agent?
I use them in combination quite often, as long as the patient do not have any absolute contraindications. And I don't necessarily use a 75 milligram per kilogram of Taxol or docetaxel. Sometimes I cut it down to 60. I mean, additional ramucirumab have a PFS and even OS benefit. We know that. So I tried as much as I can to do in combination.
Okay. And Dr. Balmanoukian, what is your practice regarding the docetaxel? Do you use it a lot with ramucirumab, or do you do it single agent?
So in the off chance that I do use docetaxel in the second line setting, I will combine it with ramucirumab just to maximize the outcome for the patient. Just because, as Dr. Jang said, the benefit is there and it's been shown, as long as, of course, there's no contraindication, but I will combine it with ramucirumab. Yep.
Okay. It's interesting. So I was reflecting on a study that was published that I'm sure, you may have also seen, which was the SWOG S1800A. And that looked at pembrolizumab plus ramucirumab versus standard of care therapy in previously treated lung cancer. And so what was curious about that in this study is that the most common agent in the control arm for the study was actually docetaxel plus ramucirumab. And I thought that was actually very interesting, where in the community, a lot of people are using docetaxel ramucirumab. Even more people are using docetaxel ramucirumab, at least in SWOG, the SWOG represented sites, which are diverse. More people are using it than just docetaxel alone. So I'm just going to kind of reshare my screen here again. 1 second. I'm just trying to do that to show you some elements of this. So again, the SWOG S1800A looked at docetaxel, and here shows the control arm, and I'll just kind of come in onto this a little bit more a bigger way, is that so the docetaxel plus ramucirumab was 45 patients out of 67. The docetaxel was only 3 for monotherapy docetaxel. Gemcitabine was 12 patients. Pemetrexed was 1 patient. So really, I thought this was actually very interesting to show too, is what is actually happening in practice around what is the standard for chemo post-progression on the PD-1. So in this study, there was 166 patients that were assigned, and 30 patients were ineligible based on certain eligibility criteria that they used. And then 69 got ramucirumab plus pembro, and then the 67 got standard of care therapy. Again, this was presented with first author Karen Reckamp. So throughout this, we've had a lot of Southern California representation, across each of these studies here. But just to kind of show, I think just jumping to the chase here in this study was that if we look at the patients who were included, again, patients had adenocarcinoma as well as squamous, so both were included. And also, the previous immune therapies were diverse. Some people got pembrolizumab. There were a lot of people who got, some people who got nivolumab, certain people who got durvalumab, as well as atezolizumab. The durvalumab patients were most likely those that were stage 3 that then went on to become stage 4. And just cutting to the chase here around the response, you can see that this combination of ramucirumab plus pembro had an improvement in overall survival compared to the investigator's choice chemotherapy. And then, this is the OS. Here is the PFS. The PFS actually didn't have as marked a benefit. In fact, PFS with chemo outperformed the ramucirumab plus pembro in this study. So I may ask, actually, maybe Dr. Balmanoukian, I'll ask you this question first. Is in your practice, did this data influence your practice at all? Like, are you using ramucirumab in the second line? Would you ever use it? And have you used it kind of just in combination with PD-1? Has it influenced your thinking in the space?
So it has definitely influenced my thinking. I think all of us were interested in this data when it came out last year. We actually have the phase 3 trial now at Cedars, the Pragmatica trial, that's looking at this combination ramucirumab and pembrolizumab versus standard of care. So it's open at Cedars and accruing. But in practice, I haven't adopted it just yet. But I do think that the data is compelling, but it hasn't changed my practice. Not as of yet.
In Dr. Jang, actually, are you using this at all in the second line?
Personally, no. I mean, this is actually a phase 2 trial. I mean, the number is small. So it really kind of interesting for me to see the data and kind of thinking about it. But I guess I'm waiting for some confirmatory trial. And also, I'm looking for some other, potential other approaches, because I understand a lot of these patients already seen one lines or anti-PD-1 or checkpoint already prior to this. So I'm somewhat skeptical about it. So I'm kind of waiting for confirmatory trial to really change my practice if necessary.
It's interesting. I mean, I think, and I agree with you, it'd be nice to see in a phase 3. I think having a phase 3 study in this space will give us better definition on the control arm is one issue. Having more data in this space, especially with docetaxel ramucirumab, if this is the most commonly used strategy in the study. And then second, I think that, how a study that shows an overall survival benefit, but no PFS benefit, or less of a PFS benefit, how that will also play out, I think is also interesting to think about here. It's curious, actually. I remember kind of being or seeing this poll that was done once where, I do think in the community, this type of regimen is being used to some degree. And I think one way that I think, people have used it is in the context of having a regimen that includes docetaxel RAM, and then continuing with the RAM with the, with the PD-1 after that or such, if a patient can't tolerate docetaxel. I think some other points, and again, we're kind of going deep into docetaxel, partly because it was the most common second line agent that was used here, is there's different practices around how much docetaxel can patients get. Actually, Dr. Balmanoukian, I'll ask you this question is, on average, if you were to think about this, like how many cycles of docetaxel do you think patients are tolerating? It is dosed until progression, but what in practice actually does that actually mean for people?
Yeah, I think thinking about it in terms of length, how long they're on docetaxel, I think on average, my experience has been about 4 to 5 months that I've seen some type of response tolerability until, they come off. So on average, I would say probably about 5 months. But it's usually, especially when they've had chemotherapy in the frontline setting, it's usually within the first few weeks that we get into issues with anemia or neutropenia and such. So some type of myelosuppression. So, it's not uncommon to see patients not feeling well within a few weeks of starting therapy.
No, and I agree. And I think the type of trajectory for a patient, whether it's they've had an intrinsic resistance to the IO based combination in the first line, those patients are going to go from intervention with chemo into needing to perhaps go into another intervention with chemo with a short interval in between. Or the converse is those people who have had, response to the IO plus chemo, and those patients may really have a long maintenance period for which their cytopenias and general tolerability for the medicine could be improved as they then go on to get their second line. And a lot of clinical trials in this space are stratifying patients based on their earlier response to the IO as they then go on to get the next line of a therapy. So just some interesting points. Well, I think we definitely covered a lot of points here. I did want to end in the last
Can I say one
5
thing?
to 10. Oh, yes.
Since you mentioned about the dosage of docetaxel, I remember, docetaxel has probably or been around the oncology field for probably close to 25 years, if not longer, I remember. And people kind of using docetaxel, kind of like try and error. I see all kind of way of doing it, like a GI specialist is playing around 5U for 25 years. But even up to today, okay, if you ask me what is the weekly optimal dose of docetaxel, nobody knows. No one knows. And people have been trying doing weekly docetaxel, Q3 week we know is 75. But what I'm trying to say is really, we still really don't know what is the best dose or less toxicity dose for docetaxel.
Yeah, I completely agree with you. And to be honest, I think one of the mindsets in chemo around a maximally tolerated dose is kind of being revisited. I mentioned our trial with the ipilimumab, nivolumab, and oxaliplatinum. One of the key components of the trial was actually looking at a dose that could cause immunogenic cell death, but be tolerable in the long run. And also, recognition that not all chemos work the same in terms of their synergism with IO and how can we monopolize on that. And oxaliplatinum may have more synergistic effect than carboplatinum based on preclinical models, which is why we paired it in the context of, the dual IOs type of strategy based on the preclinical strategy. So, no, really important points. I will also mention that at a World Lung Conference meeting, there was a presentation of docetaxel plus pembro, and it was a single institution study done in Europe, and it actually showed, quite a benefit with that combination compared to just the docetaxel alone. But it's not gotten a lot of press or kind of visibility. And I believe it was probably because it happened before the pandemic and also a single institution, type of study. But I think the field would be benefited, I think, by having a larger study that looked at docetaxel plus PD-1 to see what that endpoint could be. and I know that there are some studies underway or ongoing with that type of combination. So, just in the last 5 minutes that we have, I wanted to hear, just some thoughts about what we think are like up and coming or kind of good things to watch for. Dr. Balmanoukian, I think, and I know you do a lot of clinical trials in this space, a lot of IO as well as, other types of approaches. From your vantage point, what do you see as something that we should keep our finger on the pulse with or kind of be aware of in the space of post-progression on PD-1? What are your thoughts here on that?
We've been looking at a number of new immunotherapy targets, whether it's agonists or additional inhibitors or, in the tumor microenvironment. Nothing has really been a slam dunk. Nothing has shown exciting results. Of course, we're still looking. There are a couple of trials that are showing some potential activity. So we'll see if those actually pan out. Those are all in the phase 1 setting. Me personally, and I'm not just saying this because we got this program, I've actually been having this discussion with a few patients. I'm actually excited about the antibody drug conjugate as a class becoming available in non-small cell lung cancer. Only because, especially for patients, say, with very low PD-L1 expression, who don't really have targetable mutations, when they progress on frontline therapy, it really is incredibly disappointing. And so I think this class of drugs becoming available opens up an avenue and options for patients.
Super interesting to hear that. And I think it is also great to hear about those dual checkpoints. I think one of the readouts that people are really looking at a lot is TIGIT, because there was a press release also that, there was improvement in survival, kind of with the TIGIT combination. So we'll see how those dual checkpoints and obviously we'll also see the further data with the ADCs now that we saw that press release with datopotamab around the PFS and still needing more information on the OS. Dr. Jang, actually, what is your thoughts on kind of, agents that you're excited about in the space or kind of things that you may be, recommending to patients for clinical trials in this setting?
Well, initially today, I thought you and we did not talk before this, but initially I thought you were going to talk about EGFR mutation after OC. So that's kind of what I'm thinking about, but this is completely different. But hey, I'm actually excited about the Her3 space, really, because if you look at the TROP2, it's 65, 75% expression. I mean, Her3 can be close to 80, maybe even 85% overexpression in non-small cell lung cancers. So I'm kind of high on, patritumab. That's the ADC I'm kind of looking for. I think that will be probably up and coming and most likely may get approval soon based on what I see. So Her3 ADC is what I'm kind of high at.
I think that's really important. And just as a clarifying point, actually, the reason why I didn't, go through EGFR in this one is we have a whole section on EGFR that will, we'll talk also about the, multiple lines there. Dr. Lashkari, any last words here on this topic and in the discussion today?
Well, I mean, I think that this is an area where there's quite a bit of unmet need, and I think that's kind of the big point from my standpoint, because when I see my patients and we've kind of gone down through the road of exhausting immunotherapy and the traditional frontline chemotherapy agents, then the next question is, what do we do? And typically in those situations, if my patients are fit and capable, I try to get them on a clinical trial. I think that's important. And of course, a lot of the agents we've talked about are still in development and awaiting potential regulatory approval. Otherwise, yeah, I mean, we're looking back at kind of the same treatments that we've had in our toolbox for a long time, and our goal is to try to move those aside. So, using docetaxel and ramucirumab, and while it's nice that we have that, certainly we need to move the needle further. And as Dr. Balmanoukian said, I think seeing a small improvement even in these patients, while meaningful, really, we want to see kind of bigger improvements. And so, I think targeting new areas, whether it's antibody drug conjugates, which look exciting, or other combinations of or other novel therapeutics that are out there. I think that's really what I am looking for my patients, and so and I'm sure others as well. So that's how I look at it from my standpoint.
No, I think that's such a key point, is the unmet need, and the fact that we really need to know how to use the agents we have, but we need new agents that can really usurp and kind of synergize with the previous line that the patient may have received. One person commented to me that if any agent looks exciting, it's always kind of brought to the front line. But really, this space post progression on PD-1, there is an unmet need. So I think this is key to really think through. So with that, actually, just I think we'll close the discussion, and want to thank our discussants, Dr. Balmanoukian and Dr. Jang. Really, the comments and the discussion was fantastic, and really enjoyed hearing all the different perspectives. And thank you, Dr. Lashkari, and I'll let you kind of have the final word too.
Thank you. Well, I want to again thank our discussants, as you mentioned, Dr. Balmanoukian and Dr. Jang. Thank you so much for making yourselves available. I also want to thank our sponsor, AstraZeneca, for help supporting tonight's conference. And finally, I wanted to mention that we have another lung cancer webinar next month on September 27th, where we'll be discussing the role of neoadjuvant and adjuvant immunotherapy in the treatment of early stage non-small cell lung cancer, another area where we're seeing a lot of development and changes. So we look forward to seeing you then. Thank you, everyone.
Thank you.
Thank you.
Thank you. Good night.
Bye.
Good night.